Okay, Michael, thanks very much. That was a very detailed and interesting presentation and state of the art. Just a couple of quick comments. What percentage of biopsies do you think a year from now are going to be done transperineally?
Yeah, I think it's hard to say. So, right now we don't have a separate code for performing biopsies transperineal, and because the transperineal approach does require a little bit more in the way of disposables, in particular if you use something like the precision point device, there really isn't the compensation really isn't quite there. So it's a little bit of a problem. Right now, we are working to appeal to the American Medical Association to amend existing codes so that we could get higher reimbursement for it. If we're able to tackle that, I think as high as 30% of biopsies in this country could almost overnight become transperineal based on the amount of interest that we've seen in this. If
Great.
we're unable to achieve that, there is a bit more of a hurdle here because doctors can't be losing money when they're performing these biopsies. And so docs will really have to figure out how they could use the ASC or the hospital environment to do it, where the payment is such that it pays for the extra supplies. I think right now we're probably only looking at 5 to 10%, if that, among docs in this country performing the transperineal approach. The interest, though, is significantly higher than that.
Yeah, we looked at we've done over 1,000 transperineal mapping biopsies, which is a little bit different, as you talked about in the beginning of your presentation. And when we went back and looked at the data, we were really surprised at the lack of urinary tract infections. I think there are only 1 or 2 that we're seeing, and we thought there's something wrong here. But in fact, what you've shown actually supports that also. The next question is 3D biopsy is working on a needle which is variable anywhere from 15 to 50 to 60 millimeters for biopsy. How do you see that being integrated into what you're doing, if at all?
So I'm familiar with that product, and I think it's absolutely critical. Whether you're performing transrectal or transperineal biopsy, oftentimes the throw of the needle being standardly about 1.8 centimeters, so 18 millimeters, is just not enough to cover the full area that you're trying to get at. So I think it's very important that we have a tool available to us that allows us to take longer cores and really to be able to dial the length of that core to the length of the anatomy of that patient. And so right now we perform a 20-core sector biopsy, as I described, only because of the limitations of the length of the needle. If the needle was longer and variable in length, we could probably get that down to 12 cores very, very easily and still sample the gland.
And we found that that becomes important when we first started doing mapping biopsies. Pathologists were reimbursed on a per biopsy basis. So if we get 100 biopsies, they get, and then that sort of went away, and that created sort of a roadblock for what we were doing. So that's exciting. Anything else you want to add to the presentation before we sign off?
No, just that, I think there's a good group of transperineal biopsy enthusiasts now in the United States, and we're all very, very eager to teach this technique to our colleagues throughout the country. And so I welcome anyone to send me an email, and I'd be very happy to talk about starting a transperineal biopsy program at your institution. I think it's what's right for our patients, and we would love for you to join the movement.
Thank you so much. Appreciate it. Have a good rest of the day, Michael.
Take care.